hernia is one topic from which questions are asked in each and every exam, and ranging from 1 to 3 questions can be asked in each and every exam. So that is why hernia is an important module for all the exams. Now we all know the definition of hernia is protrusion of a viscous or a part of viscous through the wall containing it. Hernias can be of various types. You can have an uncomplicated hernia which will have both reducibility and cuff impulse will be present. An obstructed hernia is when the contents become obstructed. That means reducibility and cuff impulse are going to go away, but the blood supply of the contents is still intact in an obstructed hernia. Strangulated hernia is, on the other hand, a hernia where the blood supply also becomes compromised. That is a strangulated hernia. In a strangulated hernia, you can get skin changes as well. You can see that the skin overlying the hernia will also appear inflamed. With regards to the content of the hernia, the two main contents are omentocele and enterocele. Omentocele is if omentum is the content, enterocele is if bowel is the content. Now, omentocele, no peristalsis will be present. In enterocele, peristalsis will be present. Omentocele will have a doughy consistency. It is easy to reduce the first part and it will have a dull note on percussion. Enterocele, it is difficult to reduce the first part and it will have a tympanic note on percussion. For all hernias in general, there are 3 types of surgeries. You have herniotomy, herniorrhaphy and hernioplasty. Herniotomy is the basic surgery where we are going to open up the sac. We are going to reduce the contents, as you can see, and we close the sac. In herniotomy, we don't do anything to the defect, which is why there is a highest recurrence rate in herniotomy. Right? But you should know that herniotomy is still the treatment of choice in congenital inguinal hernias, in inguinal hernias in children, and in congenital hydroceles. It is still the treatment of choice. Herniotomy is still the surgery of choice, which you should know about. Herniorrhaphy is when you bring the defect together, when you do a tissue repair, that is herniorrhaphy. And hernioplasty is when we use a mesh. So majority of the surgeries in hernia these days are hernioplasty, where a mesh is placed over the defect, and this has the least recurrence rate. Now, questions regarding mesh materials and the best mesh composition has been asked in the exam. So best mesh is a low weight mesh with thin fibers and large pores. This is very important. Low weight with thin fibers and large pores. This you should know. This has been asked in all possible exams. So mesh also shrinks. So the ideal overlap of the mesh, should be 5 centimeters beyond the defect. That is the ideal. But minimum 2 centimeters beyond the defect, there should be an overlap. But ideal is 5 centimeters beyond the defect, so that shrinkage, even if shrinkage occurs, then recurrence does not occur. So mesh materials can be synthetic or biological. Synthetic are avoided when there's infection or strangulation. For example, Proline, Vipro and PTFE, these mesh materials are avoided when there is infection. Biological mesh materials can be used when there is infection, and examples are acellular human dermis, that is alloderm, and acellular porcine dermis. So this you can see is a simple Proline mesh which is used quite frequently. This is alloderm, which is a biological mesh. Another way of using the mesh is to use a plug mesh, but the problem with a plug mesh is that a collagenoma can form, because the problem is it is all clumped together, so collagenoma can form. That is one of the problems of a plug mesh. Now, inguinal hernia is the most common hernia. Indirect inguinal is the most common in both males and females. Please remember that, both males and females. And clinical test, the single best test is the deep ring occlusion test. 20% patients have a occult contralateral inguinal hernia. This question was asked in both the NEET exam and the super specialty exams, and this is a direct line from Bailey and Sebastian. The types of indirect inguinal hernia: you can have a bubonocele where the hernial sac crosses the deep ring. Funicular indirect hernia is when it crosses the superficial ring, and inguinoscrotal or complete hernia is when it reaches right down to the testis. You know the inguinal hernia anatomy. You have a Hasselbalch's triangle. Hasselbalch's triangle boundaries have been asked. It is found bounded by the outer border of the rectus, by the inguinal ligament, and you have the inferior epigastric vessels which form the lateral boundary. So this is the Hasselbalch's triangle. Any hernia which comes through the Hasselbalch's, through the Hasselback's is direct, and lateral to Hasselback's is an indirect inguinal hernia. Another term which is getting a lot of importance in hernia, and this question was asked last year as well, is the myopectineal orifice of Rochard. Now, the myopectineal orifice of Rochard is bounded by the arching fibers of internal oblique, inferiorly by the pectineal or the Cooper's ligament, medially by the outer border of rectus, and laterally by the tendon of iliopsoas. And the importance of the myopectineal orifice of Rochard is that it covers the defects of three hernias. It covers the defects of three hernias: inguinal, femoral, and obturator. So three hernia defects are covered. So if by laparoscopy, if I can put a mesh to cover the myopectineal orifice, I am taking care of these three hernias. Now, inguinal hernia surgery, we are doing a mesh repair. So it is a hernioplasty which is being done. Now, it can either be done via the open method or the laparoscopic method. If we are doing the open method, the complications of open inguinal hernia surgery, you can have hemorrhage, injury to the vas or the cord structures. The most common nerve injured is ilioinguinal. The most common nerve injured is ilioinguinal, and this is usually injured when you're cutting the superficial ring. The most common nerve entrapped is the iliohypogastric, and this nerve can become entrapped beneath the mesh, and this can give rise to chronic inguinal pain. So chronic inguinal pain, I've told you, recurrence and wound infection can also be there. Now, there can be laparoscopic inguinal hernia surgery. There are two procedures, TEP and TAP. TEP stands for total extraperitoneal repair. This is total extraperitoneal repair. This is technically a more challenging procedure, but it is a better procedure, right? Because we are not breaching the peritoneum. It is a better procedure. It is technically more challenging, but better. So one more thing, one question which was asked last year in one of the exams, that in 8 to 14% patients, there can be an inadvertent peritoneal breach while doing TEP. So that is the documented literature. In 8 to 14% patients, there can be a peritoneal breach while doing TEP. TAP is transabdominal preperitoneal repair. This is transabdominal preperitoneal repair. This is slightly easier to perform than TEP, and here we are breaching the peritoneum and then we go into the preperitoneal space and we put the mesh. Now, one question which has been asked in all 5 years, last 5 years, if I talk about this question, has been asked multiple times, that is triangle of doom and pain. This probably is the most important thing when it comes to inguinal hernias. Now, triangle of doom and triangle of pain. Triangle of doom is bounded by the vas deferens medially, the testicular vessels laterally, and you have the peritoneal reflection inferiorly, right? And the peritoneal reflection inferiorly. It includes the external iliac artery, the external iliac vein, the genital branch of genitofemoral nerve. All these are included. These are the contents of the triangle of doom. That is why in the triangle of doom, we should not place a suture or a stapler, because we can injure these vessels and there can be bleeding. Adjacent to it is the triangle of pain, which is bounded by the testicular vessels medially, peritoneal reflection laterally, and the iliopubic tract superiorly. Now, this is called the triangle of pain because three nerves lie here. You have the lateral cutaneous nerve of thigh, femoral nerve, and the femoral branch of genitofemoral nerve. You need to know that lateral cutaneous nerve of thigh is the most commonly entrapped nerve here, and that can give rise to meralgia paresthetica. There can be pain and paresthesias along the distribution of the lateral cutaneous nerve of thigh, and that can give rise to meralgia paresthetica. Now, triangle of doom and triangle of pain, if you combine them, you will get the trapezoid of disaster. This was asked in the AIIMS exam 4 years back. Another term which has not been asked but can be asked is corona mortis. Corona mortis, or the circle of death, is an abnormal communication between the obturator and the iliac vessels, and this can be injured behind the pubic tubercle during laparoscopic inguinal hernia surgery, and this can give rise to very difficult bleeding to manage. So these terms, triangle of doom, pain, and corona mortis, you should know for the exam. There are certain special inguinal hernias. One of them is a sliding hernia. This is also known as hernia en glissade. Commonly in elderly males, posterior boundary of the sac is formed by a visceral structure, and that is the importance, that when we are separating the sac, we can injure this structure, right? When we are separating the sac, we can injure this structure. Left side is more commonly affected than the right, and the most common structure which is there is the sigmoid colon. Sportsman's hernia was asked last to last year in the exam. This is also known as Gilmore's groin or athlete's groin. Seen in athletes, it is usually because of a tear in the posterior wall muscle. The investigation of choice here is MRI, and we have to carry out a laparoscopic repair. The European Hernia Society classification has been asked twice in the last 3 years, and when we are doing the European Hernia Society classification, groin hernias we reported as lateral or medial. Medial would be direct, lateral would be indirect, F would be for femoral. Right, each finger breadth would be given as, that is the defect, 1 finger breadth, 2 finger breadth or 3 finger breadths, and you will label it as primary or recurrent. This is the incisional hernia or the ventral hernia European Hernia Society classification, and this, if you can remember, very good, because what was asked in the exam was umbilical hernia is M3. This was asked 2 years back in the exam. Umbilical hernia is M3. So if you can remember this, excellent. You also have a Nyhurst classification. Nyhurst classification has only been asked in super specialty exams, not in the PG exams. It has not been asked. Type 1 is an indirect hernia with a normal ring. Type 2 is indirect hernia with an enlarged internal ring. Type 3A is direct with posterior floor defect only. 3B is with enlargement of the internal ring and posterior floor defect. 3C is a femoral, and 4 is a recurrent hernia. Now, femoral hernias versus inguinal hernias. So, femoral hernias are below the pubic tubercle, whereas inguinal hernias are above and medial to the pubic tubercle. The anatomy of the femoral ring, you know, the femoral ring is bounded by the lacunar ligament medially, by the septum which separates it from the femoral vein laterally, by the pectineal or the Cooper's ligament inferiorly, and by the iliopubic tract or the inguinal ligament superiorly. Now, the importance of knowing this is that this is surrounded by rigid structures on 3 sides. So, when you have rigid structures on 3 sides, what is going to happen? That the ring will not expand. Okay, ring will not expand. That is why femoral hernias have a high rate of strangulation. That is why femoral hernias have a high rate of strangulation and obstruction as compared to inguinal hernias. Differential diagnosis of femoral hernias. Inguinal hernia can be there. I've told you how do we differentiate it. That femoral hernias are below and lateral to the pubic tubercle, whereas inguinal hernias are above and medial to the pubic tubercle. You can have a psoas abscess and inguinal lymph node or saphina varix can also be there. The management of femoral hernias, again we have to do laparoscopic repair and we have to place a mesh. Ventral hernias. Ventral hernias are abdominal wall hernias. They can be epigastric, umbilical, paraumbilical, traumatic, Spigelian, lumbar, parastomal and incisional. These are the various types of ventral hernias, and amongst ventral hernias, the most common ventral hernia is an incisional hernia. This has also been asked in the exam. Now, when we do surgery for ventral hernias, there are various types of repairs and you should know these repairs. Onlay is when you place the mesh on top of the rectus sheath. On top of the sheath, you will call it onlay. Inlay is when it is at the same level as the rectus sheath, right? Then retromuscular, as the name is saying, retromuscular is behind the muscle, and preperitoneal, this is also known as sublay, and intraperitoneal is IPOM. This is what is gaining a lot of popularity these days. IPOM is intraperitoneal placement of mesh. IPOM is intraperitoneal placement of mesh. So these are the various places where mesh materials can be placed while doing surgeries. Incisional hernias, 30 to 50% of open abdominal surgeries and 1 to 5% of laparoscopic surgeries, patients are going to develop incisional hernias. This is what an incisional hernia looks like. It is a hernia in the region of a scar, and the repair of incisional hernias, we usually do a mesh repair, but you should know that tissue repairs like Keel and De Silva are not preferred these days. This is very important. Ramirez component separation. This has been given in Bailey and in Sebastian. This is done if incisional hernia volume is more than 25% of the abdominal volume. Then we fear that there will be loss of compartment, because if you close such a big defect, there will be loss of compartment, which is why we do a Ramirez component separation technique where we give releasing incisions over the abdomen. Epigastric hernia is also known as fatty hernia of linea alba. This term has been asked, more common in young fit males. Single or multiple defects can be there, and the structure which herniates out is the preperitoneal fat. You can see here epigastric hernia. For all the ventral hernias, I've told you the treatment is either onlay, inlay, sublay, preperitoneal or IPOM. We have to place the mesh. This is an umbilical hernia when the umbilicus is everted. This is umbilical hernia where the umbilicus is everted. There is more space here in an umbilical hernia. An umbilical hernia in a newborn child. In a newborn child, we will do conservative management. We do conservative management till 2 to 3 years of age. Right? Only if the hernia persists beyond 2 to 3 years of age, then only we operate these patients with umbilical hernia. Otherwise, we don't need to do surgery. They subside spontaneously. Paraumbilical hernia is when umbilicus forms one of the boundaries. When umbilicus forms one of the boundaries of the defect, this is a narrow defect. It is a narrow defect. There is high rate of strangulation. There is high rate of strangulation in these patients. And all paraumbilical hernias require surgery because of the high rate of obstruction and strangulation. Now, there are two more abdominal wall defects from which a lot of questions have been asked. You have omphalocele and gastroschisis. Omphalocele is a defect through the umbilicus where the bowel fails to return inside. The important point is that it is covered with a peritoneal sac. It is a large defect, so liver can also herniate. It can be associated with congenital anomalies like Beckwith-Wiedemann and trisomy. Gastroschisis, on the other hand, is a defect adjacent to the umbilicus, and the bowel is not covered with peritoneal sac. The bowel lies exposed, right? Less congenital anomalies are seen in gastroschisis, and atresia and perforations are more common. So you can see here omphalocele will be through the umbilicus. It will be covered with a membrane. Gastroschisis, on the other hand, you can see the bowel is lying exposed. It is not covered with a membrane. That is gastroschisis. This is another case of gastroschisis where it is not covered with a membrane. Lumbar hernias can come out through the lumbar triangles. There are two lumbar triangles which are there. So inferior lumbar hernias are more common than superior, and secondary hernias are more common than primary. What does that mean? Secondary means that there has been a surgery. Supposing a nephrectomy has been done or a thoracotomy has been done, and then through that defect a hernia forms. So it's mainly secondary than primary. The inferior triangle is bounded by the iliac crest, external oblique and the latissimus dorsi. Spigelian hernia is also known as intraparietal hernia. It is also known as intraparietal hernia or Spigelian hernia. And here the defect is the sac is going to lie in between the muscle layers. So in Spigelian hernia, the sac lies in between the muscle layers, which is why it is detected late. It is detected late and it is detected when strangulation occurs. It is detected late, and when strangulation occurs, that is when Spigelian hernias are detected. Obturator hernia is also known as little old lady's hernia. It is common in elderly multiparous women, and because there is a narrow defect, there is a high rate of strangulation in these patients. Patients with obturator hernia can come with bowel obstruction, pain, and Hoscheb-Romberg sign. So Hoscheb-Romberg sign is shooting pain along the obturator nerve. On flexion and internal rotation, you will have shooting pain along the obturator nerve. That is known as Hoscheb-Romberg sign. The Hannington-Kiff sign is absent adductor reflex in the presence of positive patellar reflex because of obturator nerve compression. So these signs, both Hoscheb-Romberg and Hannington-Kiff, are occurring because of pressure over the obturator nerve. Richter's hernias can be seen whenever you have a narrow defect. So this would be seen in paraumbilical hernias. This is seen in paraumbilical. It will be seen in obturator, and it is seen in femoral. It is seen in femoral hernias. So whenever there is a narrow defect, the entire circumference of the bowel does not herniate. Only a portion of the wall protrudes through. And because portion of the wall protrudes through, the initial complaints are of diarrhea or gastroenteritis. So initial features are of diarrhea and gastroenteritis, which is why strangulation can be missed initially in Richter's hernias. Madel's hernia, on the other hand, you can see it's a wide defect, and this is known as a W-shaped hernia. More than one bowel loop can herniate through. This is a Madel's hernia. But one thing which you should remember in Madel's hernia, that the strangulation occurs in the junction which is joining the two loops. So strangulation usually occurs in the junction which is joining the two loops. Congenital diaphragmatic hernia is another very, very, very important topic from which questions are asked. You have Bochdelic and Morgagni hernia. Bochdelic is more common, and this is left posterolateral. This is left posterolateral, and there's a defective development of the pleuroperitoneal canal or membrane, which can give rise to this problem, and the contents which can herniate through a stomach, spleen, and transverse colon. Morgagni is right anteromedial, defect in the central tendon, and it is usually the transverse colon which herniates through. So the clinical features with CDH, the patient is going to have scaphoid abdomen. Patient has scaphoid abdomen, and the patient is going to have respiratory distress. So scaphoid abdomen is going to be there, respiratory distress is going to be there. This is what congenital diaphragmatic hernia looks on imaging. These days it can also be detected on prenatal scans. This is what a Bochdelic hernia would look like. And the management of congenital diaphragmatic hernias, you should know that bag and mask ventilation is contraindicated. Bag and mask ventilation is contraindicated in these patients. And pulmonary hypoplasia or non-development of the lung is the most common cause of death. It is the most common cause of death, pulmonary hypoplasia. Pulmonary hypertension is the second most common cause of death. It is the second most common cause of death in these patients. And the management for these patients is surgery, in which we have to repair the diaphragm by putting in a Prolene mesh. That is what we need to do to repair the diaphragm. So congenital diaphragmatic hernia, you should also know that IPPV, intermittent positive pressure ventilation, is the best way to ventilate these children because they have pulmonary hypoplasia and they can be hypoxic. So IPPV is the best method to ventilate these patients. So that was regarding hernia revision. Hernia is a very important topic. You should all revise it before the exam. Thank you.